1.5 years of continuous interlearning since we started in broadcast in May 2020. The importance of digital health in healthcare systems is undeniable, as it represents a fundamental pillar for improving the efficiency, accessibility, and quality of medical care. Today, March 21, 2024, we continue our webinar series with the British Embassy, with experts sharing the British view on digital health. We will talk about an essential topic with the aim of promoting the exchange of knowledge and a broad analysis based on the British vision of advances in digital health around current challenges in the Andean region, ensure universal health coverage and access. It is important to highlight that the Andean Health Organization, Hipólito Nerones, we promote health and well-being. The essential for the health of people because it allows to respect their rights, deal with their needs, and potential their capacities. It also contributes to prevent and reduce the risk factors that affect the physical, mental, and social health, such as inequality, discrimination. Therefore, from the Andean Health Organization, Hipólito Unán Agreement, we promote positive peace as a fundamental value to have a sustainable health in our region. It is also essential to strengthen intersectoral and transdisciplinary work capacities, regional integration, and international cooperation to make social and environmental justice a reality, as well as to understand that boys, girls, and adolescents are not the future, they're the present. We firmly believe that a One Health approach is indispensable to achieve the highest possible level of health in our populations. The development and well-being of our populations depend on what we do now. Reflections on these and other priorities relevant to health and well-being can be found in the monthly Notis Salud Andinas newsletter, available on the website of the Andean Health Organization and in the Andean Integration Knowledge Showcase. We invite you to leave us your name, organization, and country from which you are joining us through the comment box of the Facebook or YouTube live chat. In the same space, you can leave your questions or send them via email to webinarhorasconu@gmail.com. To access a certificate of attendance to this webinar, as usual, you must fill out a short survey and leave your data in the fixed link found in the Facebook or YouTube live chat. Please remember to check that your email is spelled correctly. This webinar has a particular dynamic. We will start with institutional greetings, followed by the keynote speeches, then the comments of the presentations, and then start the dialogue with the questions asked and the experts present in the room. To begin this important day, I give the floor to Dr. Maria del Carmen Calle, Executive Secretary of the Orasconu, who will give the welcome. Go ahead, Dr. Calle. Thank you very much. Well, good morning, good afternoon, and good evening from wherever you are connected. I am pleased to welcome you to this new virtual meeting organized by the Andean Health Organization, Hipólito Unán Agreement, the Orasconu, and the British Embassy. This space for dialogue and interlearning takes on special relevance in the current context, where digital health stands as an invaluable opportunity to strengthen the health systems of our region. In the digital era, the internet has become a fundamental social determinant for development, transforming the way people live, work, and relate to each other. Digital technologies are a determining factor for the future of global health, with unprecedented potential to ensure universal health coverage, protect populations from health emergencies, and improve the health and well-being of millions of people. Digital health, understood as the application of technology to healthcare, encompasses a wide range of tools and platforms. including mobile health applications, electronic medical records, telehealth, telemedicine, teleeducation, among others. All of them aim to improve healthcare quality, reduce costs, and empower patients. The COVID-19 pandemic has accelerated the digital transformation in healthcare, driving the use of telehealth and remote patient monitoring. It also contributes in climate change. This second webinar in the series will give us a first-hand look at the UK's experience in implementing innovative digital health strategies and solutions. The British vision of strengthening health systems can provide valuable insights and promote dialogue to address current challenges in the Andean region. The Orascon, whose strategic plan for integration in health 2023-2030 presents 5 strategic lines, the fourth of which focuses on integration and regional cooperation as key pillars for the development of digital health. It is important to highlight the intersectorial and transdisciplinary work, regional integration, and international cooperation to achieve social and environmental justice, as well as collaboration between the different stakeholders in the health sector. And it's essential to ensure sustainability and equity in access to health services. The Orasconu, in its commitment to the right to health and well-being in the Andean region, has dedicated an important space to the promotion of digital health through different initiatives. We have conducted several webinars on telehealth, use of data in pandemic management, diagnosis and digital transformation in health systems. We had a regional competition on the Andean region on successful experiences in telehealth during the pandemic. In addition, in collaboration with the Copenhagen Institute, we have worked on raising awareness among decision makers on the importance of digital health training and the training on data security. At the next extraordinary meeting of Ministers of Health of the Andean region, the REMSA, a resolution on digital health will be presented with the objective of creating a working group to drive the development of a regional strategy in this area. In this webinar, we will have the participation of renowned experts, such as Dr. Madhukar Bose, Director of Digital Health for Healthcare UK, Dr. Bala Schreider, Specialist of the British National Health Service in the UK, and Dr. Michael Wilkinson, we welcome, who's a digital health expert of the Empathy Project. We will undoubtedly bring valuable perspective and knowledge to this debate. Likewise, the presence of panelists such as Dr. Boje Ellensen, Director of Health Copenhagen Institute for Future, Dr. Leonardo Rojas, Executive Director of the Telemedicine Office of the Ministry of Health in Peru, and Dr. Bernadette Isabel Cotrina Urquiaga, Director of the Telemedicine Center, NATE, will enrich the discussion with their experiences and analysis from a regional perspective. And relevant national authorities, such as Dr. Ciro Abel Mestas Valero, Vice Minister of Health Benefits and Insurance of Peru, and other representatives of different health portfolio to advance in a comprehensive and integrated manner towards a robust digital health system that benefits patients, providers, and health systems as a whole. I invite all participants to make the most of this space for exchange and learning, to ask questions and contribute to the construction of a shared vision on digital health in the Andean region. Thank you very much. Thank you, Dr. Calle. Now I will give the floor to Mr. Rodrigo Acevedo on behalf of the British Embassy in Peru. Go ahead, Mr. Acevedo. Thank you very much. And welcome to this journal, to this day, with, and of course, to the virtual attendees. I'm going to give a brief introduction. I'm a specialist of health at the British Embassy. Our priority of the British government not only to use the experience that Peru has in terms of health and digital health at the international level, but this can be applied in the health systems of each country. Today's session is extremely interesting for me, so I am sure that Dr. Wilkinson, Dr. Bose, Dr. McAllister are going to be very useful. Continue with us, please, and be pending for the next upcoming. Thank you for opening the event with Dr. Irabel Mesa Valero, the Vice Minister of Health Benefits and Insurance, Ministry of Health Peru, for opening this event.
Good morning, everybody. Thank you very much for this meeting. Muy buenos días a
Bienvenidos
todos.
a Good morning to everyone,
Todos los asistentes y miembros
all
de
the
la embajada
attendees
británica
and members of the
de
British
los
Embassy
países
from
indígenas.
different countries.
Reciban el caluroso saludo de la
My warm
Presidenta de la
welcome
República de
of the
Perú.
President of the Republic of Peru.
Siempre es un gusto estar en esta embajada.
It's always a pleasure to be here
Nos acoge
in this embassy
como un país hermano de todos
as
los
a
países andinos.
brother country
La
of the
relación
Andean
entre el Reino
countries.
Unido,
The relation with the
países
UK
de los Andes,
in the Andes, Andean
este tipo
countries
de
is
eventos
strong,
cada vez se
and
hace
this
más.
type of event is more common and frequent.
Vuestro país, Reino Unido,
Your country, the UK, we have much to learn about the health system. And in the health system, one of the major strengths of this information that are based on evidence taken from the patient for decision-making at a country level, and also the adequate surveillance of the different elements make up the health system, human resources, communications, and many others. And this is done through governance in health. Something I want to do in the Andean countries, and the Ministry of Health of Peru is working together with Horas Conu, proposing international standards of interoperability in order to have one health among the Andean countries. Those who visit us this country that has so many things to show us. So we have this good governance. We make that the country makes adequate decisions in health, so they can do research, and through database evidence, they can create health policy. And also, it helps us to have better collaboration and better service to the country. This as a consequence of this, all the societies that don't have this relationship in terms of network. The Andean countries are very important for the country. We are the largest water reserve in the world in the context of climate change. Countries have the largest reserve of oxygen, the lung of the world, the Andes and the Amazon region. The populations that live there should be taken care of. And with digital health, even better. They are the ones who are going to take better care of these reserves, which are not only from the Andean countries, but it belongs to the planet as a whole. And these are the populations that live in the Andes and in the Amazon. Having said this, we thank you for hosting us here and the professors that are with us, Dr. Jose and others of the Wilkinson, much for coming para esta cooperación. After the greeting institutions, I introduce myself, I'm Yadira Salas, Coordinator of Digital Affairs at Eurascono, and I am pleased to be in charge of moderating this webinar. We will start with the presentation of the experts. We have changed the agenda very slightly. Dr. Gary McAllister will give the first presentation. Go ahead, Dr. McAllister.
Hello, everyone. I can't understand Spanish, but I'm saying hello. Nice to meet you all. Do you want me to start my presentation now?
Yes, please, start your presentation. Yeah, yes, please, you can start.
Bala, do you want me to start? I can't hear you.
Yes, Gary, you can start, yeah.
Oh, okay, thanks. Right. Present my screen.
Voy a presentar mi pantalla.
1 second.
You have to ask him to go to the English channel, please.
Okay, Gary.
Yeah.
If you'll see 3 dots at the bottom, if you can click and go to interpretation and go to the English channel.
Okay, 1 sec.
Next to reactions, there is 3 dots. And then if you click on that, it'll say interpretation.
Okay.
Yeah.
Okay, 1 sec.
Can you
I need to come back to present one. I'll do that.
can you hear me now, Dr.
Sí, hasta ahora sí los escuchan, ¿no? ¿Se escuchan?
Just give him a minute. I'll try and see what's going on with him.
Hi, I'm back. Sorry, I couldn't present my screen. Let me. There we go. Can everybody see my screen now?
Yes, Gary, can see.
Sí.
Wonderful. Wonderful. So I'll just get started. So I'm Gary McAllister. I'm the Chief Technology Officer for London, but also the Chief Technology Officer for England. But the job title is slightly different. I'll give you a slight overview of the NHS, talk about our national priorities and how we've gone from some work that I've done in London to a national architecture. And then we'll talk about vision and the future and platforms and EPRs and how everything comes together within England and beyond. But the NHS was founded post-war It's made up of 7 regions, so London being the biggest region from a population perspective. But equally, as we've evolved over time, we've gone from different commissioning structures to where we are today. So the NHS is based around what we call integrated care systems and 7 regions which govern those integrated care systems. So there's 42 integrated care systems, there's 7 regions, and then there's NHS England, which looks after the country. So I work for NHS England and I work for London region as well. There's an NHS constitution which really articulates the purpose of the NHS, but ultimately it's providing healthcare free at the point of access. There's about 2 million interactions with the NHS a day. So there's quite a lot of interactions more broadly, and it's about between 1.8 billion and 2 billion pounds of funding just for healthcare made available every year to run the service. So it's a large national institution. It's the largest employer in England as well. And standards and quality and delivery is at the heart of the constitution, and values, good values across the service. It's structured in a hierarchy. So the Department of Health and Social Care is the policy body with NHS England and Improvement merged. It's as the kind of central governance structure which deploys policy across the NHS. And I've talked about integrated care systems. But then at the front line, you've got care providers, so NHS trusts and organisations that deliver care themselves. So there's 5 pillars in the NHS. It's primary care, secondary care, social care, mental health and community services, and they all work together to deliver the best outcome possible for an individual patient. Again, coming back to the structure and where we are 80 years post the establishment of the NHS, we do have these things called ICSs, but we've talked about primary care, which is GPs, voluntary sector, which is out of sector, so provided free of charge through charitable sources, social enterprises and private organisations as well, delivering care. And it's broadly distributed from a funding perspective. So there's national funding which is distributed to ICSs to then manage on a place and neighbourhood basis, on the basis of local need. So we've moved away from one size fits all model of health and care to integrated care systems which deliver care based on the populations that they serve. My role over the last 5 years has been predominantly based in London. In the last year, I've been the National Director of Technology. So I'll talk a bit about the work that we've done in London around connecting healthcare, and then we'll move on to the national footprint and the national priorities as we go as well. So I talked a bit about the 5 pillars of health and care in England. And what we did in London is because the systems that work across London are so disparate and heterogeneous, we created something called the London Care Record, which brought together all of the healthcare domains into a single system so that you can view the health and care from a single point of access. Now that works well for a region and it works well for bringing ICSs together, but there are challenges with that, and I'll come on to that in a bit later when I start talking a bit more about our national footprint. But it's just worth identifying that the national strategy for quite some time has been based around federated technology programs delivered at the point of care, but then integrating across integrated care systems and regions to provide what we call shared, or what we did call shared care records, but connected care records is the modern term. But ultimately there are many patterns to connect health systems, and in London we use a suite of standards called the Integrating Healthcare Enterprise Standards, and they provide you with a single repository of patient information for the 10 million citizens that live in London. An interesting statistic, there's 5 integrated care systems in London, all with a rough population of about 2 million people, and 30% of the treatments for those populations are treated outside of one of their integrated care systems. So as an example, I live in Southeast London, which is an integrated care system. And for certain treatments, I would have to go outside of Southeast London to be treated 30% of the time. So 3 out of 10 times I'll have to go somewhere else to be looked after. So the shared care record concept is very important and pertinent when it comes to the distribution of systems in London. I suppose just to give you a bit more breadth nationally, there's 6,000 GP practices in England, and there's about 200 NHS trusts in England as well. So there's quite a broad health service when it comes to the treating of individuals. And therefore, every single system, every single organisation has their own system, which makes it very difficult to have a single source of truth for an individual in England. But we'll come on to that and the strategy in a moment. London was built around 3 levels, so we work on an unstructured database at the moment, but then working more towards structured data with the London Health Data Strategy, and ultimately patients have access to their records through the NHS app, which I'll go into a bit more depth later on as well. We use Cerner technology in London, but equally we use standard data technology to connect information in London and provide population health analytics through the London Health Data platform as well. And we have the NHS app and other patient accessible systems. This is the breadth of connectivity that we have in London. To create London, there is a significant amount of integration required to have a single patient record across London, and taking that nationally, you can imagine it becomes even more complicated. So as we progress in England and we talk about the vision, as I progress with the presentation, we'll talk about how we're trying to simplify this on a national scale, so you don't have to do this level of integration in order to get a single source of truth for an individual. Because ultimately, this approach to connectivity is reasonably unsafe. It's very difficult to get a single source of medication, a single source of allergies, a single source of diagnosis. And another interesting fact, if you're a chemotherapy patient in London, you have to carry a card on you, because there is no single way of sharing the fact that you're on chemotherapy. And some chemotherapies are quite dangerous based on the regimen, and therefore if you go into an A&E or an emergency department and they're not aware that you're on chemotherapy, you can be treated inappropriately, which then can have significant consequences. So our digitalization is not where it needs to be. And this is what our London system looks like. So it's a block of tabs where you can see the information about an individual, and it brings all the information together from this map that I showed you a moment ago. As well as that, we have this concept of a care planning system in London. So you have a single care plan for an individual, a unified care plan, and that allows us to share information across organisations from a single system, which means that you've got a read and a write record for a person in London. So if you are on an end of life care pathway, you can be your wishes can be met through this. So another interesting statistic is we went from roughly 1 in 6 patients being 1 in 6 patients died in their place of preference before we deployed the universal care plan, to now 4 in 6 patients dying in their place of preference because of this system being deployed. So it's very good for making sure that patients that are on an end of life, certainly at this point in time on an end of life care plan, their wishes are met. But we've moved beyond this now. So we've also done sickle cell pain management. We've done work around diabetes. And as you can imagine, the single unified care plan becomes more prolific across London with the more diseased groups and more clinical specialties and services that we work with. It's very well used. London Care Record is very well used. It's used nearly 2 million times a month now. These are old statistics, but we have 10 million citizens, so we're trying to get to 1 view per citizen per month is the ideal outcome eventually. and it's a layered architecture. I won't go into too much detail about that, but we'll get into the national landscape now. So taking London as a complex landscape today, when you go to the national level, it gets even more complicated. And as we stand today, we've got like a complex plethora of national systems and services, which again make it very difficult for us to have a single source for a patient, a single source of truth for a patient. And we've done a lot of work around creating a single app that's available on our phone, which enables you to connect to your GP practice in primary care. So you can order repeat prescriptions, and you can order and create an appointment. But that doesn't cover the 5 domains of care that I've talked about at the start of this presentation. So as we progress with our national strategy, we do need to get better at how do we bring the data together. So we'd really like to eventually end up here from using a data center cabling analogy from this to this would be quite nice, so that the information flows in a very streamlined way to a single point of truth for an individual, so we can treat them equitably regardless of where they present across England. We have a large population movement every summer in England because people go on holiday to the seaside resorts, and at the moment, it's a worry. So looking at the national priorities, just talking a bit further about vision and where we're going, we've got kind of 5 key national priorities. So we've just put forward our spending review for the next 5 years, 3 years actually to 5 years, but it's given us an opportunity to spend roughly £3.4 billion over the next 3 years on these 5 key areas. So the first one being, we want to create a national data platform to improve population health and improve the treatment of individuals based population need, operation of the NHS through the use of data. It is used optimally across the whole of the NHS, and using data systems and AI to drive that initiative. Secondly, we're looking at using the NHS app, moving more monitoring at home and driving care from being what would be a reactive service to a proactive service, which is very important in the modern day as people become sicker and the population grows. We've got a big drive to fix the NHS infrastructure, so that's make sure that PCs and equipment is as fast as it can be at the point of care. We want to deliver better frontline digital services, so make sure that there's no paper in our hospitals and in our services, and then that there are better systems to connect all of the organisations that deliver health and care in England. The problem we have with the NHS at the moment, we've gone through a big merger, which means that we've got lots in the centre. It's we're looking at NHS England and NHS more broadly. I suppose the most important thing that we ourselves with today is making sure that what we devise and what we create strategically, we are using ourselves, and we're working to stabilise our health service through co-design. Our architected, and therefore we have a national architecture programme which looks at creating a single national architecture for the NHS, and we'll come on to that in a bit more depth in a moment.
Gary, just to let you know, your suddenly all of a sudden your signal's weak. I think you're breaking up quite a lot.
Hi everyone.
There's a lot of
Can you hear us, Gary?
yes, but there's a lot of background noise, Gary.
Hello?
There's a lot of background noise of people talking around you.
Do you want to pull your screen up? Share your screen, Gary.
Let's try again. Can you see where I've got to?
Yeah.
Let me try and move. Am I back online? Is it a
Yes,
bit
you are.
more
You're back
stable now?
online. Yeah.
All right,
Yeah.
right, okay, great. Let me try and let's carry on, and then if it's more of a, I'll try and move to my phone if it's an issue. So we've got this through the technology tier of our strategy. We're looking to ensure that everything is within tolerance. Technology debt is a big issue for the NHS, so we're working on improving that and driving better technology. We've got a set of architectural objectives, which is about ensuring that we've got an architecture framework. We're developing business blueprints. We've got information standards that we're improving as well. We're setting our architectural vision and we're stabilizing the organization, which has gone through quite a challenging merger over the last few years. We're working with a new publishing methodology, which looks at publishing things early, getting feedback from our customers or our colleagues in the NHS and patients and other parts of the health service, and then iterating over our policies so that we are better aligned with the front line, listening, evolving, adapting, and then ensuring that the funding is being delivered for the right problems to deliver the right outcomes. Our data standards are complicated and we do need to standardize our standards, but we use SNOMED CT heavily in the NHS. Open EHR is an evolving standard, but really important as we create our clinical data repository. And we use of IHE heavily FHIR across the NHS. ICD-10 and OPCS is quite significant in our NHS to ensure that we code and then cost and then pay our providers effectively. And standards are vitally important to the delivery of our health service, and we continue to evolve those and make them more accessible at the point of care. We are working on some legislation, so it's really important to note that legislation is important. One of the challenges we've had in the NHS more broadly is that we've not had enough levers to pull when it comes to the standardization of standards and then the deployment of standards across the NHS. So we are working to get through some legislation which gives us more power in the NHS to ensure that suppliers actually adopt standards as they're published, which means that data can then flow more readily to the centre and we can create that single source of truth. At the moment, if we publish standards, it takes many years. So some of the standards have taken up to 10 years to get adopted. And as we progress, that's just simply not good enough. We need to have standards deployed, published, deployed, adopted, and then in use within 12 to 18 months in order to get the benefit of them. So it's a radical shift from quite an old archaic methodology to a more streamlined legislative approach to the deployment of standards. So very important part of our strategy. We have an interoperability strategy, so then using those standards to connect systems and ensuring that the information flows to the centre and then back out to individuals through a very well-established set of pillars and tiers so that data is in the right place at the right time for the right person to deliver the right outcome. I won't go into any detail. So this is where we've got to with our one digital architecture, and I'll close on this and a couple of other pertinent points. So we are in the process of defining our national architecture for the NHS, which provides us with a blueprint of how and where services are to be owned and deployed, and then how we're going to start creating new modernised services for the aggregation of data in the centre so that we can make the NHS safer to deliver care, empower patients and ensure that they've got more ownership of their care through monitoring, population health, better, more streamlined, aggregated, converged services at the front line, aligned to systems, delivery and development, enabling clinical networks to evolve and mature, underpinned by good clinical, operational and digital foundations. So this is the blueprint of the future that we're working on. We're currently going through consultation on this slide, so it is draft, and there's a lot of work to be done around ensuring that this gets published, understood, evolved and iterated based on the outcomes and the user-centered approach that I mentioned to you earlier. And then just to finish, I think one of the nuggets of the NHS, which we should be really proud of, is our NHS app. It's now used by 3 in 5 of our population roughly, It's deployed to many millions, over 30 million people. I think we've got the NHS app now in England, and it's growing, and it's the crown jewels really. But we have to be able to stabilize the data and provide some sort of core information service to the app so that it's safer, more effective, and patients have more control over their healthcare. So I hope that's been helpful. I mean, I mentioned at the start, you can use it to book appointments, you can use it to manage prescriptions, and then moving forward, you'll be able to, take more ownership of your care. So I'll stop there. I'm sorry if my internet connection has been slightly unstable for you, but it's a whistle-stop tour of the thinking of the NHS and how we've gone from, as I say, from a systematic approach and now moving to a more national approach to the management of data and innovation, and really focusing on population and outcomes around individuals and complex individual needs. So thanks for listening to me. Sorry for connectivity challenges. And I hope you enjoy the rest of the presentations that you've got this morning. And best wishes.
Muchísimas gracias. Muchísimas gracias, doctor.
Thank you very much, Dr. McAllister, for your valuable intervention. Possible if you could stay in the room, because again, we're going to have a Q&A session with all the people present. We know this is somewhat complicated for you, but we will highlight some of the relevant things that you've mentioned, different standards of comprehensive health insurance. Now, we will introduce Dr. Madhukar Bose, Director of Digital Health at the Healthcare UK. Dr. Madhukar is leading the growth of the UK digital health exports and investment globally, has spearheaded pioneering initiatives such as digital health demonstration in China, the healthcare AI catalyst in India, and the UK digital health handbook. He has also led trade missions to Brazil, USA, UAE, China, and India. He has 10 years of experience in managing, consulting, working with clients such as the NHS, Roche, Novartis, and Pfizer. In addition, he established a telehealth company in India and has an MBA graduate from Cranfield School of Management. Welcome, Dr. Bose. Go ahead with your presentation.
Thank you. What a delightful afternoon. Thank you so much for the invitation to speak. Let me share my slides and start with my presentation. Can someone confirm it is visible and
Yes.
audible?
Perfecto.
Yes, Madhi.
Yes, go ahead.
Great. Thank you. So Gary was talking about the NHS and the NHS's vision for London and beyond. I'm taking a slightly different perspective here. I work, as the introduction mentioned, I work for the Department for Business and Trade, which is part of the British government, looking at exports out of the UK and investment coming in, and various other initiatives around making those two objectives work. I will not go into the details of this, but just to set the scene. We are, within the department, part of what is called the Science and Technology Directorate. And there is a vision that the Prime Minister set out some years ago about making and growing the UK's reputation as a science and technology superpower. And I think the idea here is that the UK has always had a very strong research and science base, and we will look to enhance that, but to use that science and research base to create technologies that are going to transform our lives for the better. There's so much of development going on right now, and the pace of that development is growing all the time, especially when you look at what is going on in the AI space at the moment, as an example. So digital health, which I will talk about today a bit more, and the UK's expertise in that, is one of those areas where the research element drives the innovation and drives, therefore, the transformation of healthcare into the future and the NHS of tomorrow. So if you look at the UK's digital health ecosystem, I have put 9 elements on this slide that help understand what drives the UK's digital health innovation ecosystem, what creates that innovation, what are the different pillars and the ingredients that you need to really make a digital health enabled healthcare system in the future. So the first element I'll touch upon is innovation hubs. There are parts of the UK where you have a set of drivers. So you have bodies that allow innovators to set up their offices, and along with others, and they access the NHS through that ecosystem. So if you look at some of the names on that slide, you have the Oxford ecosystem, which is called the Hill, the accelerator there. You have Propel, which is in Yorkshire in the north, Digital Health London in London. And these are all built to support innovators with new innovations to grow, to find a place to access the NHS, and to access resources and mentorship and guidance from others to really help them on their journey. The growth pathway element is all about supporting innovations go beyond the growth, the early stage. Because one of the main challenges that we face, and Gary was talking about London, if you look across the country, you have a very fragmented healthcare system. The NHS is not on the surface of it a single organization, but it is made up of a lot of smaller trusts on the hospital side, more than 200 of them, and more than 3,000 on the general practice side, so GPs practices. So it's quite a fragmented delivery system. And Gary was highlighting some of the issues around integrating the information around that. But it also creates a challenge for innovators to grow, where you have to go to every single organization if you want to sell to them, and for those organizations to assess what the innovator is offering and to successfully build that and take that innovation in. So there's a lot of repetition of effort, and the growth pathways initiatives like the Accelerated Access Collaborative are all designed to make that journey smoother. There's already a restructuring of the healthcare system, consolidating the procurement of and purchasing of digital health. Rather than at 200 plus hospital trusts, you do it at 40 plus integrated care boards and systems. Gary mentioned that London has 5 of them, and the rest of the country has many more based on the population sizes usually. So that is designed to increase or improve the procurement and purchasing situation. I won't spend a lot of time on some of this, but I just wanted to highlight a few of them a bit more. So funding and investment, whether that's government or private funding through the venture capital network, that's vital. There's a lot of that coming in, especially around some of the transformative technologies like AI. We'll touch upon AI a little bit more later on as a specific example of how the government in the UK has funded digital health growth. Centralized infrastructure. Now, Gary was talking about the London shared care record or the single care record. At a national level, you have the NHS Spine. And I'll talk about that a little bit more as something that is at the heart of the country's and the NHS's functioning, not just from a digital health perspective, but from a healthcare delivery perspective. It plays a key role, but it also allows different solutions to function in a way. Indirectly, it allows the digital ecosystem to grow around it. Aligned interests. So this is making sure that the health system is set up in a way that innovation can be adopted, it can be reimbursed, so that things like telehealth and teleconsultations are reimbursed in the same way, or at least there is a reimbursement available for those technology-based services, while you pay for the normal physical delivery of service. So quite often the issue is that digitally enabled services are not reimbursed, and therefore it creates a barrier for innovators coming in. Now, data is one of the key assets for the NHS. The NHS collects a huge amount of data at local and national level across the different care pathways and different elements of care, whether that's primary, secondary, social care, tertiary. So all of that data is then made available through different channels for innovators to build their innovations on. There are a few examples that I've put here. I won't go into the details here, but for example, in the AI space, there are a number of different hubs that are created so that data for to develop AI solutions can be accessed through those. HDR UK is one example of a hub ecosystem, so that if you are looking at, say, developing innovation around cancer, you can go to the cancer data hub, and that will pull all data from a few trusts who have signed up to that, and that data can be made available for the development of innovation. But if you look at all of the data-driven technologies that we're producing, then having that data ecosystem is absolutely key. There are other elements such as the upskilling of workforce, the NHS workforce, to adequately leverage the technology that's being produced. There have been a number of reviews at a national level that have looked at the both the leadership of digital health from a clinical perspective. So how do you enable or encourage the healthcare system and the clinical element of the healthcare system to take a leadership of technology, because it cannot be a technology-led transformation. It has to be a clinical-led technology transformation. So the clinical leadership is important. You also have the general workforce and making sure it is able to use technologies like AI into the future. So you then have the idea of gaining public trust and trust from clinicians, and finally the regulation element around, especially around emerging technologies like AI. There is a new approach that the NHS is using for regulation of AI to bring together multiple regulating bodies, such as the National Institute of Care Excellence, Health and Care Excellence, which does the health technology assessments, and the Medicines and Healthcare Products Regulatory Agency, which decides whether the technology is safe or not, and CQC and the Health Research Authority, the four of them coming together to create a single body that will regulate AI solutions, so that it doesn't become a barrier. So both the growth pathway that I was talking about earlier, which is about making the procurement easier, and then the regulatory system, which is able to regulate both, ensure it's safe, ensure technology is safe, but also make that a quicker and more streamlined process. So all of these elements come together to give the UK a real advantage in terms of the growth of and transformation of digital health and the healthcare system. So I'm going to quickly then look at a few different areas of healthcare expertise that the UK has. What we have done is bring those together into what is called the UK's Digital Health Playbook. It talks about 8 different areas where we need to address challenges and where we have solutions to address challenges. The first one is about supporting healthcare professionals in making better clinical decisions, enabling patient-centric care beyond traditional boundaries. So it's not just about taking care of patients in hospitals or in primary care centers. It's now going outside hospitals, into people's homes, into the community. Wherever the patient is, the care has to follow. How do we get insights from the data that we are collecting? As I said earlier, the NHS collects a lot of data, but we have to get better at making sure that we are able to use that data to provide better care and treatments. Creating core infrastructure. So I've mentioned the spine, and we'll look into that a bit later. How do you create core infrastructure that enables the rest of the system to be digitized? How do we support people in looking after their own health? Certainly, there's so much interest through the internet. There's so many tools and technologies available that can help people look after themselves better in collaboration with the healthcare system. How do we improve the collaboration and communication between different parts of the healthcare system, between, say, primary, community, acute systems, hospitals? How do we improve that collaboration and communication? How do we improve the quality and efficiency of a healthcare system in terms of delivery of the service, whether that is through patient flows or whether that's through managing better the information flows within the system? And finally, how do we better diagnose patients and screen them so that we are able to diagnose earlier, we are able to diagnose more accurately, and therefore the treatment can be started and made more effective, started early and made more effective. So I'm going to focus on a few of these because time is limited, and see if we can go into those to understand what the UK has done. So the first one is the core infrastructure piece. I mentioned something called the NHS Spine, which sits in the middle of the healthcare system, center of the healthcare system, and it's able to act as what is called a health information exchange. If you look at the list on this slide, under the domain-specific apps, you'll see a number of things listed, such as the summary care record, which is second from the top. This is a short form of the overall health record that for every individual, you have, as Gary was describing for London, a local health record which will have the full set of information. But on a national level, you have the summary care record, which has a short version of it, which is usually demographics, allergies, medication, and so on. So you have blood type as well, and a few other things. So you have the summary care record, which is accessible nationally. You have the demographic service, which identifies people based on their name, address, and date of birth, links that to the NHS number, so that's a unique identifier for every individual. And there are various other systems and services like electronic prescribing, e-referrals, and you've got the directory service, and so on. So the idea here is that you have one central system that helps the digitization, while you have the individual delivery organizations taking on their own digital strategies. So if you look at the expertise that it was used to build this, you have the BJSS and AirLogic, two companies that were tasked with the majority of the delivery of this spine. I'm not going to read through that, but it will give you an idea of the complexity of the NHS spine, as well as some of the other works that I think Gary had referred to, the NHS app. That is another piece of work that BJSS had delivered, as well as the NHS website and the COVID-19 risk stratification tool. So when we look at patient-centric care, there are a few technologies and few types of applications that the NHS is really moving ahead with. Virtual wards is one. This is where, because hospital capacity is limited, the NHS is now increasingly looking at discharging patients early, or taking certain patients out of hospital, keeping them at home, monitoring their condition, where they don't need immediate acute interventions. So keeping an eye on their health at home through monitoring technologies. You have telehealth, which is more long-term condition management and monitoring. And shared care records, which again Gary mentioned, but he didn't call them that. I will use that word for now. Digitally enabled care services. So these are all, say, digital therapeutics or specific condition related services, which are highly digitized and offered in a digital form. For example, on the slide, you have Cyber Liver, which offers a specific intervention for liver care, for cirrhosis, and for alcohol-related issues, where you are able to show some real improvement through the provision of digitized care. for that specialist condition. You have MyWay Digital Health, which, for example, does a lot of work around diabetes management. They provide national services in Scotland, and 30% of the UK, I would say of England, it should be around diabetes care and advice. And the idea here is that if you are a diabetes patient, rather than simply prescribing drugs, you prescribe a whole set of digital interventions, or you prescribe them diet and lifestyle changes and lifestyle measures which are digitally driven, so that it gives them a better chance of sustainable recovery. You have other companies like Patients Know Best, who offer a patient-controlled health record rather than a clinician-controlled or an institutional health record. And those patient-controlled health record are managed by the patient. They can be shared with other clinicians as the patient needs. CliniTouch, which is a telehealth and virtual wards system, which is all about providing devices that are able to collect information and share them with clinicians to effectively monitor people in their homes or in in social care settings. The most exciting area, I would say, of growth right now is AI in diagnostics and screening. A lot of funding has gone into AI from the UK. We had the NHS lab with 250 million pounds worth of funding. And the objective there was to identify promising technologies and to give them funding to help them grow from whether they were early stage or they were ready to deploy. There were 4 different stages, but a lot of technologies were funded through that AI lab and the what was called the AI for Health and Care Awards. We also funded 5 UK centers of AI excellence, 3 for imaging and 2 for digital pathology. I mentioned the HDR UK data hubs. I won't mention them again, but and as well as the streamlined regulation, which helps AI technologies get certified as safe and then get deployed into the healthcare system. Again, very quickly, you have Chiron that diagnoses breast cancer and is increasingly being rolled out across the NHS in multiple forms. You have Behold.ai that analyzes chest X-rays and CT scans to diagnose lung cancer and stroke. Brainomics, which is a stroke specialized system, which has all of these are being deployed at scale in the NHS, so that the Brainomics system has enabled more than 100,000 stroke patients to benefit from it. Ultramix, another company, this is about echocardiogram analysis to see to diagnose heart disease, and they're all growing now within the NHS, but growing internationally as well. Supporting better clinical decisions. Now, this is a challenge around many parts of the world where you have inconsistent levels of expertise. You have not a great provision of healthcare service in certain parts which are remote. So how do you improve healthcare delivery? How do you make it consistently high value? Again, you have a number of technologies here around supporting decision making, improving the learning and development of clinicians, but also helping them collaborate to fill knowledge gaps. Elsevier is one such company that provides a decision support system that can be used in both rural and urban settings to improve the quality of the decision making, based on standards, based on guidelines, national guidelines that can be built in. Similarly, DemDX is one which has specialized in ophthalmology, working with one of the best eye hospitals in the world, Moorfields in London, plus other hospitals as well, to provide a system that will enable clinicians to make better decisions for those domains, whether that's ophthalmology or others. Pbris is one where you have AI guided software for early detection in the community of various diseases. Particularly, I know they've applied it to pediatrics and heart disease. It reduces the time to diagnosis and improves the quality of care overall. You have Proximi that uses telepresence to improve surgical delivery. So you have a renowned surgeon sitting in one location who's able to guide surgeries happening in remote locations, and therefore improve the quality of those surgeries in multiple locations. Finally, I think if you look at improving quality and efficiency as a goal, then you have a number of areas that the NHS is looking at. Triaging and patient flow management, especially during COVID, this was a focus where you didn't want patients to all land up in hospital, and you wanted to make sure they went to other places or were managed at home. So eConsult was a platform just on the side there on the slide, which was which was utilized at scale. It was a nationally utilized system in England, accessible to 30 million patients across more than 3,000 GP surgeries. I think the usage has probably reduced post-COVID, but it's still a very widely used system and the largest provider of online consultations to the NHS. You have C2 AI that uses artificial intelligence to improve quality of hospitals and individual institutions, saving both cost as well as improving the care that is delivered. Patchwork that uses staff management systems to understand both temporary, how to utilize both temporary and permanent staff across more than 50 healthcare organizations, and working in this case with more than 40,000 healthcare workers. In Touch with Health, which does patient flow management for hospitals, to make sure that you understand how efficient the patient journey is, and to improve that, to sort out bottlenecks, and especially where you're looking at a lot of hospital based care systems where hospitals are expensive, people are usually landing up at hospitals and getting seen. So making those flows more efficient is what they do. So that's a very quick summary of some of the expertise that is being deployed within the NHS to ensure that the overall system performs better and that patients get better outcomes. So I'm going to stop there. Sorry if it went a bit too fast or too slow.
Muchas gracias. ¿Me escucha? Yo
Thank
creo
you very much.
Muchas gracias, doctor José.
Thank you, Dr. Bose.
Muy
Interesting
todo lo que nos acaba de compartir,
everything
un poco
that you
también
share
la
in
importancia de la evidencia
the
científica para la
importance of
innovación
scientific
y la
evidence for
transformación del sistema
innovation
de
and
salud.
transformation of the health
Seguramente en el
system.
diálogo podremos abordar
And
este
surely
tema
during the
más
Q&A, we
ampliado.
will expand more on this
Muchísimas
topic.
gracias
Thank you
y
very
les
much.
invitamos a permanecer en
We
sala
invite you
porque
to
al
stay in the
final
room
de las
because at the end
presentaciones y
of the
disertaciones
presentations,
haremos un diálogo.
we will
¿Sí?
have a
Ahora, a
Q&A.
continuación,
Now we would like
le doy la palabra.
to welcome
Le damos la más cordial bienvenida al doctor
Dr.
Michael Wilkinson.
Michael
Él es
Wilkinson.
experto en salud digital
He's an
y
expert in
proyecto
digital health
Empathía.
on the
Él
Empathia
fue el CEO y
project.
fundador de
He's a
Inaya.
CEO and founder of
Creó
Inaya.
Chaval,
He
un innovador dispositivo
is an
médico
innovator of
con
medical
marcado CE y una plataforma de
with
inteligencia
markers and
artificial
intelligence,
que permite a las
artificial
personas
intelligence
crear, poseer y compartir
platform
su
that
perfil
people can
digital para
create and
recibir
share the
atención
digital
médica
profile to
remota
receive
y
medical care,
altamente personalizada.
remote medical care and personalized
Las
care.
iniciativas clínicas de
The
INAIA,
clinical
se
initiatives
extienden por todo el mundo,
extend throughout the
incluyendo el
world,
desarrollo de las
including
nuevas
the development
tecnologías en
of
INAI
new
con el apoyo de
technologies
Microsoft.
with the support of
INAVIA ha sido reconocida
Inavia
como una
has been
empresa
recognized as
ganador
the
y una empresa First Team
outstanding
de la
company
Playbook por el gobierno del Reino
of the
Unido.
playbook for the
Además,
government of
recibió el premio a
UK
la
and
mejor
received the
startup
award for the best startup
2023 y a
in
la
2020,
startup de medicina de
the
precisión del
medical
año en
startup
el
with
2021.
precision medicine in
El
2020.
doctor Wilkinson es un
Dr.
experto en
Wilkinson is an
innovación
expert
designado
in
por el
innovation appointed
Innovate UK,
by the Innovate
National
UK
Institute
and the
of
National
Salud,
Institute
el
of Health
gobierno del Reino
Research,
Unido y la Comisión
the
Europea.
government of the UK
Su
and the
formación
European
académica
Commission.
incluye un doctorado
He's,
de la Facultad de
has a
Medicina
PhD in
de
the
la Universidad de
medical
Warwick
school University of Marwick, where he was a fellow in research abroad. Previously was a professor of technology of information and health, where he also founded a lab of health informatics and WHO big advisor, early future lab in the National Fund of Science and Technology and Art. Welcome, Dr. Wilkinson. Go ahead. You have the word.
Thank you very much for this opportunity. We'll put these slides up. Okay, and you can hear me okay, is that correct? Okay, thank you. Once again, thank you very much for this opportunity. I'm delighted to be here. By chance, I'm in Lima, in Peru, as part of a project that we're running with the Frontier Hub and the embassy here, the British Embassy. It's called Project Empatia, and I'll explain that during my presentation. But the work I'm presenting, we'll be looking at the healthcare ecosystem as wonderfully outlined by Maddie Bose. And I'll be touching on our own journey of developing the innovation that we have around artificial intelligence in healthcare, and how we've been working across the innovation landscape in the United Kingdom, but also with partners globally, such as partners here in Peru and more widely in Latin America. The technology that we've been developing is focusing particularly on chronic diseases. And the reason for that is because 60% of adults have at least one chronic disease, heart disease, diabetes, cancer. And as people get older, they're more likely to have several conditions, and they can live with a condition of chronic illness for, say, 20 or 30 years. So we're looking at this particular issue of chronic disease management, which represents around 85 or 90% of healthcare costs globally. Is it okay? Okay, my assistant was helping me there. I'll carry on. And what happens is that when patients go into hospital for their care and treatment, they're discharged from the hospital, and typically what happens is the doctor or nurse gives them a care plan. And it's a piece of paper, and it says that you have these conditions, you need to take these pills, typically 8 to 12 pills a day. You need to eat a certain diet, take a certain exercise, and the hospital clinicians will say, we'll see you in about 8 or 12 weeks. And what happens is that globally, around 25% of these patients are readmitted into hospital within the first 4 weeks, and about 40% in the first 6 months. And the reason for this, one of the main reasons for this readmission rates is because about 50% of patients are not following their care plan. I need to see the slides. And so just one moment, I'm getting something fixed on my presentation here.
Do you want to share my screen? I got your presentation here with me.
Oh, yes, please, Bala.
Okay.
Did they not see the screen, the slides?
Just let me know if you can see the slides and I will fast forward to where it needs to be.
Okay, I'll start again just quickly, just to the next slide. Okay, we're focusing on chronic diseases. Globally, around 60% of adults have at least one of these conditions. Next click. And there's no cure for these diseases, and medication and diet help. But usually what happens is that patients go into hospital and they're discharged from hospital. The nurse or doctor gives them a care plan, which is a piece of paper, and they're told to take certain medications, to eat a certain food and exercise. And the patient takes this care plan home, and more often than not, they don't follow that care plan. Next, Bella. And 25% of these patients are readmitted into hospital within 4 weeks. Sometimes these patients die, but it's a huge cost. It's a big burden on the health service and a strain. And if you look at the data, around 50% of patients struggle with following their care plan, in particular following the medications. And this represents around 85% of healthcare costs. So this is what we're targeting. It's a very big challenge in health services globally. Next, please. And what we've done is that about 8 years ago, in terms of the ecosystem, is that I used to work in the National Health Service in the UK. I set up the National Innovation Centre for the NHS. It's one of the hubs that was mentioned. I also taught at university. I was an academic at the London School of Hygiene and Tropical Medicine. I taught in health informatics. So I came from a background of the health service, working for 10 years and as an academic researcher. But what happened when I left the NHS, I set up my own company, and I thought it would be interesting for me to use some of my skills in digital health to develop a technology to help patients who are struggling with their care plan. And what we decided to do about 8 years ago was we weren't so much looking at the patients who were struggling. We wanted to understand there were some patients, a few patients, who actually thrive. They're able to withstand all the risks, all the challenges, the difficulties that they have in life when they're managing their care plan, and they're able to thrive and have happiness and health. And so what happened was about 8 years ago, my team, when I set up the company, we put in a proposal to Innovate UK, which is another resource in the UK, for funding, and we won a grant to create what was then called the Quantified Self. Later it was called the Digital Twin. But essentially what we wanted to do was to create a machine that an ordinary person could use without understanding any computer programming at all, a machine that would be their companion, a machine that would give them the resilience so that they can have health on their own terms and outside of hospital. So we started to create a machine using artificial intelligence 8 years ago. And I have a team of scientists and a team of designers who've helped us to develop this technology. And as we've been developing the technology, we've won around 10 research grants from the UK government. And we work with many of the players mentioned, for example, NICE for regulation. And we work with universities such as Imperial College, Barts Healthcare in London, Leeds Teaching Hospital, where they help us to co-develop the technology. And the most important point about this, and Mehdi Bose mentioned this too, is that the clinicians need to be engaged, and also the patients. They need to be engaged in helping to define the problem, the challenges that they're having, but also the types of solutions that would help them to do the tasks that they need to do better. And for us, what we were interested in is helping patients to thrive, to live life on their own terms outside of hospital, so that they're defined not by their disease, but by their family, their occupation, their interests, and so on. So we started to create this machine, which I'll describe now. Next, please. And the whole idea was to create a machine that gave people the resilience or this type of intelligence so that they could withstand all the difficulty. And so when we designed our machine, which is mediated by an app, it looks like an app for a user. What we did was we created first a theoretical framework for that machine, and that's based on Buddhist philosophical constructs of the self. This is why our technology is called Avatar. And from that theoretical construct of the self, we then said, okay, what types of data would we need to be able then to create this idea of this individual, this digital self? And you'll see that also, because I come from a public health background, we're collecting data which is physiological data, attitudinal data, behavioral data, social data, environmental data, and all this data can be collected. But what's happening is it's being processed against this theoretical construct of the self so that that individual can live optimally on their own terms. And they're in complete control of the data, and they're in complete control of the machine itself, their own avatar. And in this sense, the machine acts and thinks holistically and supports the patient in all these spheres of life, including health, so that they can have a happy home life, that they can work, that they can sleep, and so on. Next, please. And as we started to develop this technology with hospitals in Singapore, in the UK, in Europe, in Italy, Germany, in Brazil, and now in Peru, what we found is that essentially the doctors often think the same way and they work the same way in terms of the technology. And they're looking for technology which can help them to make better decisions faster, and for the patients to have health and well-being outside of hospital. And so we created a machine that has tools for the patient, tools for the clinician, and also tools for the managers of the healthcare system. Next, please. Okay, so our tool set looks like this. It's on one side, we start with the clinicians, and the clinicians have, it could be on a tablet or mobile phone or on a computer. They do what they normally do in their practice, which is they set a care plan, but instead of writing it on a piece of paper, they use our system to enter the data for the patient. As I said, it will be about the types of diseases the patient has, the medication the patient needs to take, the diet and the exercise prescription, when the patient needs to revisit. But when the doctor creates the care plan using Avatar, what happens is that as they enter that data, they're actually creating a very complex algorithm. And that algorithm then is sent to the patient. It looks like a WhatsApp communication. The patient receives on their mobile phone a message from their doctor saying, this is your avatar to assist you. And the patient can accept the avatar, and it starts to interact with the patient. Now, the first technology that we have when I describe the AI, when the doctor sets the care plan, is that's based on symbolic or classical AI technology using if this, then that logic protocols. And this is an older tradition of artificial intelligence that still has resonance, especially in medicine, because medical doctors worldwide practice if this, then that logic protocols when they're making clinical decisions. They follow protocols and they follow evidence, and that leads them then to a diagnosis and treatment and managing care. So our machine aligns to how doctors actually work. It doesn't replace the doctors, it works on behalf of the doctor, supports them. But when the doctor sets a care plan using the avatar, and as I said, they create this algorithm just by working themselves. What happens is that the patient receives a WhatsApp message, and that WhatsApp message starts to interact with the patient. But what it's doing is it's starting to understand the lived experience of the patient through a conversation. What are their attitudes, their values? What types of beliefs do they have? What are the circumstances that they have now, and how do they want to live their life? It starts to have a conversation as if it's their friend, and it becomes their friend and their companion. But what it's doing is it's starting to understand this patient might be a vegetarian, they might have certain types of of interests or hobbies or social networks in their local community. And it starts to adjust the machine, the patient's machine, so that it fits like a glove for them. And by doing that, what happens is the care plan starts to become much more personalized and meaningful and contextualized for the patient. The patient can interact with their own avatar, speaking directly to it the way you would a Siri. An avatar speaks Chinese, Hindi, Portuguese, Spanish, English, many languages. And the patient can interact back and forth, or they can communicate by text. And the whole point is that the technology is there to support the patient so that they can stay healthy. And because I come from a science background, and digital health is important from a scientific standpoint, but also from the health service, we need to make sure that the technology is delivering clinical benefits and also economic benefits. We don't want to create a technology which creates a lot of clinical benefits, but it costs too much. So we need to make sure that in addition to step change improvement for clinical benefits, we also have economic benefits. And this takes me then to every interaction that takes place between the patient and the doctor goes on a ledger. We're able to measure at a granular level, in time and place and context, how the patient is performing. If they're doing well, or if they're having a problem, the doctor can get a sight of this, and then they can adjust the care plan. And this happens quite often. They need to up-titrate the medication so that the patient can prevent an escalation, say for diabetes or hypertension, and it averts a problem such as a readmission into hospital via the emergency room. We have this quite often. But by and large, what happens is when the doctor sets a care plan, the types of things that they normally would need to do, or their team, such as calling the patient and asking how they're doing and getting follow-up information, it's done by the machine now. And so our own research is showing in clinical studies that in addition to delivering clinical benefits, we're also delivering economic benefits, around a 20% savings, efficiency savings, through streamlining the personalized care plan that's set by the doctor and the patient. Now, one of the things that I would say is that although the health service is really important, obviously it is, and you have in the NHS, you have the hospitals, and you have the primary care, the mental health centers, and so on, which was mentioned earlier today. The reality is that that's part of the service provision to help a patient stay well. But when you're dealing with chronic conditions, such as the diet and the exercise and environmental determinants of health, we need to look even wider than the NHS. The ecosystem looks more widely. And so what we do with the avatar is that we're collecting information in a very wide level, but it's focused on the individual patient in time and place and context to help them to thrive. And we're using, I mentioned in the past 8 years, we've been using semantic technologies, artificial intelligence, and we've been using, this is classical AI, but more recently what's happened is that we've started to move into generative AI, which I'll talk about. And I'll also talk about a bit more about our economic analysis work that we're doing, which is getting a lot of interest. And within all of this, of course, data privacy, integration of the data into the services that was mentioned, how important that is, and security is really, really important. And Maddie both mentioned some of these elements too. And so as we're developing this technology, it's taken 8 years because we're delivering clinical benefits, economic benefits. We're ensuring that the privacy is protected and security is protected and can integrate. And this is a step change into innovation. I'll take you through some of the screens that we have now. Next, please. Thank you, Bala. The technology toolset that we have is a toolset for the patients, a toolset for the doctors, and a toolset for managers. And I'll show a few screenshots of what these actually look like. Next, please. These are the actual screenshots that the patient sees. And as I mentioned before, you see on the top left there, the screenshot. It looks like a WhatsApp interface, and the patient can interact with their avatar, and they can provide information, they can enter information, and so on. Often the doctors ask the patients to submit readings such as blood pressure, oxygen saturation, and so on. For heart disease, for diabetes, it's glucose and weight, and so on. And so the doctors can choose which types of treatments to use. The Empatia project that we're doing in the UK is focusing on cancer care with Detecta Clinic here in Lima, and to serve the population across Peru. And for them, the patients have an important need to manage pain. And so what we have are indicators for pain management that have been validated, and the patient can provide information on pain and pain treatment. And I'll come to this a little bit more in terms of the work in Empatia and the project we're doing in Peru, and why this particular service is so important in a bit. Next, please. Okay, here's another screen looking at reminders for patients to make sure that they're giving the data. They can enter the data. They can just talk to the machine and enter the data this way. They can enter it. If they're wearing a wearable device, it can just be entered by the device automatically. And this is a way for the doctors to make sure that they're getting the information into the system, so that the system understands how well the patient is doing. If there's any problems, the system can tell the patient and the doctor what the problem is and what they might be able to do to solve that. Next, please. And this is a screenshot of the doctor's dashboard. And these are some screens that the doctors have selected in Brazil, yes, because it's for hypertension control and oxygen saturation and so on. And this is a completely configurable tool set. So the data points that the doctor might want to have for cancer will be different, for diabetes it will be different. But one of the things that was really interesting for us to learn is that the doctors said several things to us that were the same in all the different markets, whether it's India or Singapore or Latin America or the UK. The first thing that they say is that they don't want to have a system where they're inundated with lots of data, because then they have to spend their time just filtering out all that data. An experienced doctor will probably want to have maybe 5 or 7 data points for a particular patient, and that will be enough for them initially, then they can drill down. The second thing that's interesting is that you'll find in the healthcare market, the pharmaceutical companies and device makers all wanted to create their own apps. They wanted to control the patient. The problem that they had is that the patient didn't want to be controlled by the pharmaceutical companies or the device makers. And the other problem, of course, is that the hospitals started to complain about having 35, 40 different apps, one for each particular condition. And this became a particular problem for patients that have comorbidities. So for example, if a patient has hypertension and diabetes, and they might have some other types of conditions, like 3 or 4 or 5 conditions, it's not practical to have 3 or 4 or 5 different apps for those drug companies and also for the device makers. And what the avatar does is it brings it all together. So there's one version of the truth, and all of this data can flow into this system, making it easier for the doctors and the patients, but also for the healthcare providers. This is something that we've been working on quite a bit as we move more and more into complex conditions and comorbidities. The AI actually thrives when there's a lot of complexity. And so this is a very exciting time for us. Next, please. These are some more screenshots. These are actual screenshots of what the data the doctors see in real time. And blood pressure, the diagnostic, diastolic and systolic blood pressures. You'll notice the little yellow dots at the bottom. What this is indicating is that the care protocol that the doctor has set is breaching from safe to at risk. And when that happens is that the doctor is notified that the patient's blood pressure has breached the safe limit and is starting to trend. But also what we're doing, you'll see at the bottom underneath there, we take a snapshot of all the data points the doctor said they're interested in. So the doctor can review when there was a breach of the clinical protocol, what factor or combination of factors might have been associated with that particular breach. And this becomes really important because, as I mentioned earlier, the patients typically see the doctor 8 weeks or 12 weeks after discharge from hospital, and the doctors say, "How are things going? What's happening with your health?" They might look at a printout from a heart monitor and see, 3 weeks ago it looked like you had a problem, and expect the patient to understand what was going on at that time. Where here, what we have is real-time contextualized data, which is evidence-based to help the doctor make an informed decision. And so this has been a very useful tool for the clinicians getting this type of data, and they control the complete tool set, and it's driven by the care plan that they set. Okay, next, please. Okay, I mentioned that we have a tool set for patients, a tool set for doctors and clinicians. We also have a tool set for managers. This is an actual data visualization of projects that we do in Brazil with INCOR Heart Hospital. It's the largest heart hospital in South America, and also with the cancer hospital there, the Cancer Institute, which is the largest cancer institute. We're able to collect lots of different types of data from the system itself and integrate that with data in the public domain and create really nice data visualizations. This is what in the city of São Paulo, what the distribution of disease is. And the lower one is looking at line graphs for hypertension. Next, please. And what I want to do now is I talked about the avatar system. I talked about the fact that we are collecting health economic data in addition to clinical data. And in the same way that the clinical data is collected in real time, so that we can see how the doctors can see how the patient is performing in real time. If there's any problem, they can intercept the decline and keep the patient well. It's important to understand that every time a doctor makes a decision, there's usually an economic consequence of that decision, whether the patient needs to take more medication, they have to stay in the hospital, if they have to come in for surgery. Every time a doctor makes a decision, there's an economic consequence. And the question is it a decision that will keep the patient healthier and reduce costs, or is it going to actually increase costs? And so what we've been doing with funding from the UK government is that we've been creating an economic calculator, a health economic calculator with a very famous professor of health economics, Anita Patel. And I'll show you some screenshots. Next, please. So what's happening is that we have 6 months left on this project, but we're creating a calculator to give clinicians and service planners, these are managers, insights in terms of the economic consequences of decisions that they make. And those that economic information is following the patient's journey at a patient level, okay, for the clinicians, but an aggregate for the managers. And I'll show you what this is looking like in terms of the experience for the user. Next, please. Okay, this is basically a prompt so that when the data is coming in and it says that there's the patient isn't following their care plan, what's happening is that we're giving a calculator message about the consequences of a patient if they stay on their medication plan or not, in terms of quality added life years, quality years. And so the doctors and the clinicians know in a very express way what the consequences are of adherence or non-adherence in terms of health, but also economic and quality of life measures. Next, please. Here we're using standardized tools again to give messages in terms of how the patient is performing and if there's an economic consequence or not. If the patient is performing well, they're encouraged to carry on, and if there's an issue, then the patient and the clinician are encouraged to explore how they might be able to address this. Because the patients also have a responsibility to try to keep costs down as well as the clinicians and to stay healthy. Next, please. And this is just another screen looking at the impact of readmission rates and costs. And so that we're making explicit the cost decisions that both a patient and a clinician make when they're making clinical decisions. Next, please. And the generative AI, I'm going to come to this in a bit, but I just wanted to say that the reason why we're doing this economic calculator work is because typically what happens is health economists around the world do retrospective studies. What they'll do is that they'll collect data and they'll say, okay, over the past 5 years, this is what has happened based on the data in terms of the quality added life years or the cost benefit analysis. And what we've tried to do is to build this into a real-time calculator so that people can make actionable decisions based on the evidence. And so we're very excited about that particular tool set. And there's a lot of interest, by the way, not just in the NHS, but in Latin America and other countries around this health economic calculator that we've integrated into our system. The other advance that we've been working on is around generative AI. And I'll come to this now. We've been sponsored by Microsoft to develop advanced technologies around generative AI to deal with this particular issue of adherence for patients. How can we use generative AI to support adherence to care plans, thereby keeping patients healthy and keeping costs down? Next screen, please. So we've been developing this technology in the UK, but also looking at the application here in Peru. And essentially, if you look at generative AI, the problem with it at the moment is it has a human-like conversation if you use, say, the chat that's coming from OpenAI. But what happens is you get a lot of hallucinations, you get inappropriate information, problems with no persisting memory, and so on. And so although generative AI has a lot of potential, it also has a lot of problems. So what we've been looking at is how to address those problems. Next slide. And the way we're doing that is that we're using generative plus a retrieval technique. And so instead of using every single source of information available on the internet, such as in Facebook and TikTok and so on, we have a repository that the clinicians control in the hospital. They say, this is the information that we want to have as a compendium of information. And there's a whole series of generative AI and language modeling techniques that we've done. But the point is that when a patient asks for information, we know that response is going to be accurate because of the source material and the validity of that material. Next, please. And this is just a high-level overview of what this looks like. It's technically very, very challenging, and it's a step change innovation that we're looking to take to the market with the clinicians to improve adherence, clinical outcomes, and cost savings. The technology is not based on, say, word search or typical database management. It's using vector databases and very advanced mathematical modeling. But my company has the skills for this, and this is why we're working with Microsoft to develop this. I've been approached also by Google, and we'll probably be working with Google also as we're developing this. And the important point about this is that you don't need a big company to do this. In fact, a big company can probably be a problem, at least early on. Many of the innovative companies in this space are really small, and they're innovating very, very quickly in developing transformational technologies. As Maddie Bose was saying, how do we take this innovation into the service safely and so it can have impact and benefit everybody? And this is what we're attempting to do in our work here in Peru, but also in the UK and other markets. Next, please. And that's it. I want to thank everybody. I think I finished on time. Thank you very much.
Muchas gracias, Dr. Wilkinson. Thank you for your presentation. We are waiting in the room. Nos vemos acá en Lima. El doctor Wilkinson se encuentra en Lima y va a participar en el diálogo más
If you find
adelante.
in Lima, could you please stay for the Q&A session? Because we're running out of late, now I'm going to start the voluntary space, and I would like to welcome Dr. Bogi Eliensen, Director of Health. He was born in the Faroe Islands, graduated in Political Sciences University in Denmark, where he had a master's in both fields. In addition, has executive training in Harvard and worked in the Ministry of Health, of Foreign Relationships and Commercial of the Faroe Islands, and worked as an advisor for the last 25 years for politicians, the public and private sector. Dr. Eliensen, in addition, lives in Berlin and has the Robert Bond Fellow and also improving of Germany. With this brief introduction, Dr. Eliensen, welcome. You have the floor.
Muchas gracias. I think there's translation, so I might do this in English.
Hello.
If that's okay. Thank you so much for this webinar and the presentations that we've had. I know we are almost to closing time, so I will try to be precise and not too long. I think it's very interesting also to hear about what is happening in UK and the plans. And just for knowledge and transparency on this, I have a long-term working relationships with ORAS as well, where we are trying to help to have a similar approach to the 6 member countries in this way. And I think there are a lot of inspirations to take on the 2 first ones on the planning and how this is applied, both for the on how to provide health, but also the business side of the health industry, the business and the innovation side of the health industry. There is, of course, a difference between UK and the Andean or the Latin American countries, and in this case, especially the Andean countries, and also where I normally live in the Nordics in Denmark with unitary systems, which makes a little bit of a difference on how you can apply things. But it's quite clear that the plan that we also heard about of trying to connect many different parts is very impressive in UK. And the way that the life science strategy, so I work a lot with genomics and also with many of those persons who are leading Genomic England. So how that came about, both to improve health, but also to have a life science sector. So when David Cameron presented it, it was half on improving health and half on being a leader in life science, on the commercial side of life science. And that balance in a UK setting, I think is very admirable and good to learn from, because we don't really see it in other places in that way. So what I think is of importance here is also to say, okay, how can we let us inspire with this for the member countries of ORAS? It's quite clear that if this is to be pushed forward, a collaboration between the countries is on its place. And I think there is a different challenge. So when we look at UK and the Nordic countries or Northern European countries, the challenge is not the technology. The challenge is the change in what we need to deal with as a health system. And that is what we heard in the last one, which is a growing disease burden. And it's the moment of time when you interact. So for instance, with applying secondary prevention much better. And given that in these Latin American countries, you actually can do much more with developing the primary care as the first point, and not going into these very advanced hospital systems first, as we had the need for before in times. And also to have in mind that this is a market of 500 million people that use Spanish for health, which requires that we work across boundaries. And this is what we also have pushed very much in our Nordic Health 2030 approach, So how do we get much more of the health budget to be preventative? So our approach is half of it. So half of it becomes on primary, secondary, and tertiary prevention. What it requires also to come into what we heard on the last presentation is quite a clear governance, because assembling data and putting AI on, I think that is what we see in many places. But what is the governance, the transparency, and with that the privacy and own control of data in that part? The biggest challenge we actually see right now is how do you secure as a country that you make the playing field of the technology that you put in, so you actually get the data solidarity and the added value of data to be a benefit for the country and not just for the providers who come in. And that should be a symbiosis, because of course you need to work with companies, and companies also need to have a revenue. So it's not about not working with companies or that they cannot make money. So here I see that the common good is something that is possible if we look at the three presentations that we have, that the common good aspect as a requirement for trying to push this development in Latin America is definitely something that should be sought for, and I would see as a common good benefit in it. Given that I've worked quite a lot in the Nordic with this question, it's not as easy as we would like it to, because you also need some data to work on. So the real-time governance and surveillance of AI, for instance, is a constant challenge to work with. I don't think anybody knows how to deal with that yet. The privacy issue is also, of course, a concern, but we have to take care of that the privacy does not hinder that we actually can work with the usability of data. That's another question, which I think is also in the air. So one of the things that I really want to push here is to say that I actually think that some of these things could be developed in this Andean region and the Latin American region, because our older health systems are too locked into an old way of thinking. So the symbiosis of coming with this technology and ideas that we have heard here, and with the needs and the eagerness to go forward in Latin America, could probably be a very, very good match that could be very exciting on going forward. So with our approach on the 5-5, we have also worked very much with this idea that we heard on the last intervention with the avatar. And I would be really eager also to hear, but we can take that on a separate call on how much is in this, how many results you have already on this. This is definitely a way that will go forward. But I think the big challenge is when we want to apply AI, what does it work on, and how do we make sure that the value also is for the person and for the society in it, because it's all about sustainability on the long-term part. And with that, I will just end with what I always say: if we are not putting dignity first, this will not fly. Thank you.
Muchas gracias, estimado.
Thank you, dear Dr. Bogi Eliasen. Very interesting insights. And that helped us to reflect. Now we welcome Dr. Leonardo Rojas, physician from the National University of San Marcos, specialist in administration of health, master in health management, in research, coordinator of the group of research of technologies, associate professor to the academic department of preventive medicine and public health. He's a general director of the General Office of Information and Systems of the National Institute of Health. He's currently executive director of the telemedicine office of the Peruvian Ministry of Health and head of the telehealth unit of the Universidad San Marcos. Go ahead with your comments, please. Good afternoon. Greetings to all the authorities. Dr. Calle, the Executive Secretary of the Orozcono, distinguished authorities and experts in this table. I'm very impressed with the presentations, especially on how the UK has been able to develop a strategy based on strengthening their health system, how this digital health strategy is part of this policy on the health in the United Kingdom. I would like to highlight from the first two presentations two topics that I would like to comment and perhaps be able to discuss with the experts. Is that, for my surprise, is that our system, set of systems, and that reminds me that is similar to some systems that we know that are fragmented and that, however, have a very large integration. And I think should make us to lead us to think that among the pillars proposed by those 5 pillars in the NHS, one of the I would like to highlight is primary care as a first fundamental pillar. It's very important to make an reflection on lessons learned. This unified plan that you have defined for each individual is that if we bring it to our reality, it's a sort of life courses that we have. However, they forget even beyond to the level of personalization of each one. But I think this is extremely interesting because science, technology, and information allows me to get to that level. Then, about the digital architecture, there's many things to say. One of the things that I enjoy is that it defines a number of international standards, adoption of international standards to our vice minister here. Every time I heard him speaking, 95% time he talks about the national standards, which tells us that we're on the right track. However, not single standard. There's a set of standards. And one of the most important is the framework of standards for interoperability. And they have precisely designed a strategy of where there are specific laws that define how we adopt these standards for interoperability, focus in that the rest of systems use these standards. One of the things that I would like to know, if it's possible, and perhaps our speakers could respond, what has been the strategy that they have defined, if they have an office or an area or an institution that deals or is in charge of defining what standards are going to be adopted, because we have many standards. They're quite variable. How do you identify the standards and then adopt it in the country and define the norm that they're present? How have everybody comply with it? Because in the Ministry of Health, we don't define our standards, but how make people as the rest of the stakeholders in the health system and the other subsystems adopt this? We can speak the same language in order to. At this moment, there is we're not in the ideal situation. I also think it's interesting to have an application focused towards the user, this NHS app that allows to manage different services and systems, and the same citizen can manage their appointments, the surgeries, all that information. And I think that together with the integration of systems and interoperability, it's is very strong. In the second presentation, something that was very interesting, one of the things that were proposed about the digital transformation of health, that this transformation is based on information. And innovation is based on research. There's no way to innovate if you don't investigate and promote this. And many of the things that you mentioned about innovation is open data for innovation and the use of standards of regulatory institutions that will facilitate innovation. In other realities, our regulatory institutions not necessarily facilitate, and many times they're an obstacle. So to think on how can I facilitate research that generates innovation to transform health is an interesting challenge. Just talking about artificial intelligence has been defined that IA is a biomedical device, and according to our standards in Peru, the biomedical devices require regulation. However, our standards don't consider that biomedical devices can be generated in a country, because the regulation is thought for the device coming from abroad with a corresponding certification. So it is important, and this is an example of how we have to do these modifications to promote innovation, transform this. Dr. Bala, I'm going to take 1 minute break, please. 1 minute break.
Vertebral que permite, que es una infraestructura que permite el intercambio de información entre los diferentes subsistemas y que permite además que la información, pues no necesito toda la información para poder atender al ciudadano, sino este resumen, un resumen que en otras latitudes le llaman conjunto mínimo de datos, donde se define una serie de datos de las personas para que se puedan intercambiar, para que este intercambio sea más rápido, fácil, sencillo, que permitan una atención integral de la persona, ¿no? Finalmente, algunas de las, hacia dónde va todas estas estrategias me parecen totalmente fundamentales, importantes, ¿no? Para que el profesional de salud tome mejores decisiones clínicas. Finalmente, la tecnología, por supuesto que permite esto, ¿no? Con los sistemas de soporte de las decisiones clínicas, por ejemplo, las atención centradas a la persona.
Person-centered care with this personalized care plan that also defines certain specific plans or programs, for example, the liver or diabetes, the exchange of information in telehealth, that this personalization, that these programs that allow reach where they are needed. It's interesting to have this integration, but also certain programs focused to certain priorities, so we can provide better care and reach the user. There's more efficiency, timely diagnosis and early treatment. Something important that was mentioned by Michael that I think is very important is that this system need to be friendly, so the user can use them easily. For that, you need to investigate. Without research, I cannot establish a system that is easy to use. And this reminds me a research we did some years ago where we used a very complex tool for the interaction between health professional and physicians for better care. And this tool was extremely complex. In fact, some physicians didn't want to use it because it had to be installed, use of password, to learn to use a tool. That's too many options. People today we use WhatsApp.
y justamente su herramienta
And
pues se basa
previously,
en el
the
uso de
tool
WhatsApp
is
para
based in the
que
use of
puedan
WhatsApp, so the user
no tenga problemas
doesn't
en
have
conocer,
any problem
familiarizarse en
in
tratar
learning
de
about the use of this tool and understand
justamente
it.
este tema de la
This
usabilidad y de la
skills
forma
and
muy visual de presentar los
very
datos,
visual
los datos
form of presenting data
vitales, esta
of
forma
vital
de
signs.
presentar es muy
This way
importante
of
porque de
presenting
eso
is
depende
extremely important
el
because
uso o no uso
the use
de la
or
herramienta,
misuse of that
porque
tool
nosotros ya
depends
estamos
on that because
atiborrados de tantas herramientas,
we're
entonces
overwhelmed by
no
so
podemos
many
tener
tools and
curiosidad por
squares that we
enterarnos
see in
de
our
cada
cell phones.
ninguno más,
We don't want to
pero
know
en la
about
medida
any new one, but to the extent that this can be useful for information and provide useful information,
si no estás siguiendo tu tratamiento, si no tomas tu
not
pastilla, vas a
following your
tener estas
treatment, you're taking the
consecuencias,
pill, you're going to
entonces
have
es algo
this
que
issue.
sí aporta
They're going to
mucho
think, yes, it is
a
important
a las
and
nuevas
health
herramientas que tenemos que desarrollar
for the new tools that
como
we need to
país
develop as a
y además
country,
deben estar orientados
and also
justamente
should
a
be
la
oriented
persona y a los intereses que
to
tiene para
persons and
poder
the interest.
utilizarlo. En el país, finalmente, en el Perú, digamos, de lo
In,
que se ha presentado,
in
nosotros
Peru,
tenemos pues una agenda
we
digital,
have a digital
tenemos
agenda.
una ley del
We
gobierno
have
digital donde
a
se
law of
obliga a todas las
digital
entidades públicas a
government that
brindar
forces
servicios digitales.
all
Entonces,
public
este
entities to
tipo
offer digital services. So
experiencias, este
this
tipo
type of
de información que
experiences,
hoy día nos han
information that
presentado
they presented us
nos
today
obliga y nos da mucho más
gives us
información
more
de cómo
information
utilizar
of
los
how
servicios
to offer
digitales
these digital
que
services
estamos obligados a dar
that we
para
are forced
llegar
to
a
provide
mejores
in order to
personas donde tenemos que llegar
reach
y
people
tenemos que
in a
pasar
better
por
fashion. And I
todas
think that that is
estas
something that I
Muchas
would
gracias.
learn from this presentation. Thank you
Gracias.
very much.
Excelente intervención.
Excellent intervention. And some
Estaremos ya
questions
para el diálogo, que seguramente
for
en los
this
próximos minutos
dialogue in the next
utilizaremos para
minute,
que puedan conversar y también
so
la
you can
participación de los que están tanto en sala
discuss.
presencial como en sala virtual. Ahora, para los últimos comentarios de
Now,
esta
for the
ronda,
last comment,
le voy a dar la más cordial
I'm going to
bienvenida
invite
a la doctora
Dr.
Bernadette
Bernadette Cotrina,
directora
Director
del
of the Telemedicine Center of Salud, Senate in
La
Peru.
doctora Cotrina es médica
Cotrina is a
con
physician
especialidades
with
en
specialties
cardiología y
in
gestión
radiology
pública
and
con más
public
de 15
management for
años de
more than
carrera.
50 years of
La
career.
primera directora
First
de
Director
telemedicina
of
del MIR de
Telemedicine in
Perú,
Peru,
miembro de la
member of
CONCITEC,
the
ganadora de diferentes
CONCITEC,
premios
winner
de
of several
Nobel,
awards in
incluyendo el de
telemedicine,
ONU,
professor
docente de la Facultad
at the
de
Medical
Medicina Humana de
School
la
of
Universidad
San
San
Martin
Martín
de
de
Porres
Porres y ha
University,
ejercido diferentes
and
cargos
he
en
has
el MIDIS y
held
educación.
different
Así que
positions in
adelante, doctora Cotrina,
public
bienvenida.
sector.
Muchas
Welcome,
gracias. Gracias,
Ina.
doctora María del Carmen
Thank you.
Calle, secretaria del organismo andino
Executive
Urasol,
Secretary of the Andean
doctor
Health Organization,
Ciro, viceministro
Dr.
responsable
Ciro,
de
Vice
nuestro Ministerio de
Minister
Salud,
of
a
the
nuestras
Ministry of Health of
autoridades
Peru,
que
authorities,
nos acompañan ahora y que auspician también
and are
públicamente el
sponsoring
evento del día de
together
hoy,
this
a
event
los
with the UK
compañeros, asesores y
and
profesionales de salud.
advisors
Importante
that are here.
comentar que
It's
nosotros
important to
desde la
mention that
seguridad
we,
social
from Social
también hemos
Security,
tomado
as it
formamos
has been
parte
mentioned,
de lo
we
que
are
es el
part
sistema de salud
of the
peruano.
health, Peruvian health
El
system.
sistema de salud
This
atiende al
health
30% de la
subsystem
población peruana,
cares for 30% of the Peruvian
más o
population,
menos a más de
approximately
12 millones de
more than
peruanos
12
a nivel
million
de
people,
toda la región.
Peruvians.
Nosotros tenemos una organización
We have
administrativa
an
lineal
lineal
integrada en todas las redes
administrative
asistenciales prestacionales a nivel de la
with
región
these
que
networks
termina
through other
operativa
regions
bajo la gerencia
that
general y bajo la presidencia
respond to the
ejecutiva que
general manager and the
efectivamente
executive
doña
president.
Elena Aguilar de la Isla le emite, señora secretaria, un gran y cordial saludo.
She sends her greetings to all of you.
Nosotros, como seguridad social,
We as Social
tenemos una
Security
infraestructura
have an
que dentro del ambiente
infrastructure
público
that in the
del
public
país tiene gran fortaleza.
space
Tenemos un
is
sistema
very
de gestión
strong. We
clínica
have
que
a
está
clinical
integrado por
management system
491 IPES que
with
cuenta la seguridad social.
several
Tenemos un sistema de
institutions,
imagen
certain
genética
institutions.
que
We
nos ha
have a system
permitido
for medical
justamente
images
empezar el
that
trabajo
have
en materia
allowed
de
us to
apoyo al
start
diagnóstico
working
y
with
marcar
telediagnosis
el eje operativo
and
de la
to
telemedicina en nuestro
talk about
país. Con esa
install
presentación
telemedicine in
y con
Peru
una mirada de una
under
herramienta
a
que es el
look
centro llamado
of
SENAT, el Centro
a
Nacional de
Senat, the
Telemedicina,
National
que
Center
ya
of
hace 9
Telemedicine
años
for
como
more
unidad
than 10 years
descentralizada y que en el
with a
país
centralized look
ha
and in time
generado ejes
has
satélites que
generated
son los
satellite
centros de telemedicina
centers like
regionales.
the regional
Fruto de la
telemedicine centers,
implementación
and
de la Red
today
Nacional de
the
Telesalud
national
para
network of
implementar e
telehealth
implementar la
to
telesalud, la salud
implant
digital y para
this digital health and to close this gap that we have that the physical offer cannot cover. So we're going to show a small video about that Social Security is working and that we have many common points with. Go ahead with this video.
Hola, soy Senate y te quiero contar mi
Senate, and I will tell you my story in Social Security. February 19 of 2013, for the first time in public health in Peru, I sent a CT that came from Huancavelica to the executive presidency office, and this belonged to Pedro, who suffered a working accident in that region. After that, I became the first in the category of offering telemedicine services in our country. And we had an own infrastructure of approximately 100 square meters. Thanks to 4 radiologists, physicians, 2 internal medical, and 1 in dermatology, I could provide care to more than 21,000 patients in several regions of the country. And thanks to teledermatology, I was able to diagnose dermatosis to Mary, who was in Huánuco. And I also could care Patricia from Cocache in San Martin region. And with 27 weeks of pregnancy, she learned about the sex of her baby. During my first 28 months of operation, I saw more than 62,000 patients that live in remote areas of the country. Thanks to the use of information technologies, I had the opportunity to learn about the diagnosis and receive specialized treatment. In 2013 and 2015, I was able to read more than 1,000 images, approximately 15,000 mammograms, and more than 16,000 tomography in more than 36 centers, generating savings in institutions of more than 10 million soles. In 2014, I won the Business of Creativity in the category of health. What a day. In 2017, another achievement, the first place in the Kailin Health with the project Teleco Pets for the early diagnosis. In 2020, COVID pandemic arrived. I was prepared that eSalud in Peru, my experience in telemedicine. So my infrastructure grew and was more modernized and more health professionals arrived. We did telemonitoring and telemedicine in different regions. In this way, we had 200 professionals working. As my growth continued, and we need to have some partners throughout the country, so we have the regional telemedicine centers. We have 7 and are located in Tarapoto, Piura, Libertad, Arequipa, Junín, Ucayali, and Moyobamba. And I have only expanded, but also I've grown in different innovative strategies. In 2023, I started working with professional and education groups and developing projects that help more insured patients. In addition, thanks to a big effort with gynecologists, I got telecolposcopy with a timely diagnosis of cervical cancer. The survey began in Loreto, where I've been able to take care of more than 60 patients. And I just started Teledot together with the nurse staff. We treat tuberculosis through telemonitoring, achieving that our patients that are not with PVC can receive their medication at their homes. From our inauguration in January 25th of this year, we got seen more than 900 cases and we have more. I haven't forgotten the most vulnerable, our children and elderly. Together with medical technologies, we provide rehabilitation therapy for speech language therapy, as well as other pathologies. And in the elderly centers of Telecam, the elderly are very happy because we have reached to provide teleorientation in psychology, nutrition, physical therapy, and a recent program of neurocognitive stimulation with specialists in speech therapy. Just in 2023, I saw more than 1.2 million care in different medical and non-medical specialties.
competencias. Y para lograrlo,
And
les
to
propongo
achieve that, we provide teletraining in the YouTube channel that they can find on Senate de Salud. My concern goes beyond medical consultations. I'm concerned for the well-being of the population, wishing that a person adopt healthy lifestyle and provide health. And so I'm sharing information through what we call TeleYek, an effective way to connect and build a road to a healthy and full life. And today I'm proud to show you this program of teleeducation, Teleeduca, strategy that will allow the population to be educated in public health issues, topics, achieving health and promotion of health using information technologies and communication. As Senate, I have the responsibility to work implementing telehealth nationwide. That is why I'm deploying the national network. I have more than 40 tele offices throughout Peru where Salud can provide and train health professionals to deal with other patients. I'm sure that it will continue growing in order to become a Latin American referral. And together with my telehealth observatory, I will take care of the needs, always considering that in Senate, we humanize technology to provide health.
Compunche Perú, Gobierno del Perú.
Gracias.
Thank you.
Muchísimas gracias, doctora Cristina.
Thank you very much.
Antes de iniciar el diálogo con todos los presentes, tanto en sala como en sala Zoom, fue parte de
Before starting the dialogue,
nuestros webinars de siempre agradecer a las personas conectadas.
thank the people that have joined us,
Los que nos acompañan,
people from
especialmente a todos esos funcionarios de los
all
ministerios de
these
salud, de las academias,
officers from the Ministry of Health, social organizations, academic institutions, public and private institutions connected from Germany, Argentina, Belize, Bolivia, Chile, Colombia, Cuba, Ecuador, Spain, US, Guatemala, Mexico, Nicaragua, Paraguay, Panama, Dominican Republic, Peru, United Kingdom, Uruguay.
Dicho todo esto, a partir de este momento,
At this moment,
le pido por favor a todos los que están en sala,
all those in the room, including a special guest, we're going to start the dialogue. And if somebody would like to participate, and if not, I'm going to ask some questions. Dr. Leonardo, he asked, what is the strategy that has defined the UK to use some type of international standard, what type of office, type of standards, and what type of unit to establish a common language for operation. So the question is open. I don't know if Dr. Bala or the team from the group of the UK. Dr. Bala, go ahead.
Hi. Could you just, if the interpreter could repeat the question for me? It was a bit faint when you were speaking. If you can just speak up to me.
Okay. La pregunta la había realizado.
The question was made by one of our people comment, Dr. Leonardo, related to all the experience that you presented. What was the strategy that you have used as a country to find those international standards for interoperability? How you establish the selection of that type of language and what suggestions? Okay.
Okay, got it.
Sí.
Thank you. Thank you. Yeah, it's a pleasure to meet all of you again. I think the key here was, as I said, the UK adopted the first and foremost the standards of IHE, International Health Exchange, as a standard for interoperability, and making sure, we are now moving to HL7 FHIR as a standard language. So between the minimum communication between systems. But again, as Gary had mentioned, there are multiple standards, and we're making sure that the standards are applied not only at the NHS deployment end, but also from making sure the suppliers who provide those, the systems to us adhere to those standards. I think contractually, we were initially, some of this were providing with extended language, and then the others were compliant with HL7 FHIR. So it's the three things was XDS, FHIR, and HL7 was in that HL7, XDS, and FHIR were the standards that was available within the healthcare system ecosystem. But what is happening now is we have more or less standardized and agreeing with our suppliers to provide that to enhance our interoperability. And we're also trying to make the standards vendor agnostic. So making sure, we can push data without the dependency of which supplier is providing us with EPR or the patient record systems. The data belongs to the patient, and the data belongs to the organizations, not to those vendors. So this was the biggest challenge we faced in the early years. The vendors locked the data in, and we were unable to extract and push data as we felt we should do. So to enable that to happen, we move towards a vendor agnostic standardized platform, so that we can harness the data and make the data available at the point of care.
Muchas gracias, doctor Bala.
Thank you, Dr. Bala. Somebody else from the UK would like to.
I think I'm the only one left to answer your questions, because the others had to leave. Yes, Gary is actually on annual leave, but so he joined us, as you can see from wherever he was. And so I'll be happy to take more questions and can come back with you with more specific answers for them.
Igual, para aprovechar el diálogo, antes de dar la palabra, ahorita la doctrina, voy a hablar más. ¿Ahora sí me escuchan? ¿Ahora sí? No está abierto. Está usando su micrófono. ¿Ahora?
Ahora.
Sí.
Ya, con el micrófono de acá, cambiamos de micrófono. Perfecto. Tenemos
we change the mic. We have two hands raised. First, Dr. Boyelsen and Dr. Cotrina, would you like to start? Followed by Dr. Boye.
Una de ellas, de los 9 elementos. Dentro de las presentaciones que hemos podido escuchar.
Following the presentations, you mentioned the 9 elements or principles that generated innovation in the digital health systems. One of them was especially considered to earn trust for the public. We from Peruvian Social Security, we have started a TeleIEC program, which is one of components of the Telesalud Act in Peru that talks about training in education. Is a modular structure. It has contents for the target audience. Is it that how the experience in order to earn the trust, this learning in health with a target audience in digital work?
I think, is that question to me?
Yes.
Yes, okay. So I think you are
Creo
absolutely
que
right. I think at the end of the
tiene toda
day,
la razón al final del día.
the key principle is, as I mentioned, the value of the NHS Constitution states the data belongs to the patients. You know, whatever health data we collect and hold, it actually we are just custodians. We are looking after the data for the patients. So in order to ensure that there is granularity, that they have confidence, that they have understanding that we hold the data and we use the data for the right reasons, trust is a key priority, key instrument for ensuring that the governance structure that is placed around is robust enough to deliver that assurance to the patients. So digital health data is, we are very clear as to what the data is used for. The primary principle of the data usage is data is available for what we call direct care. So as and when the patient is needed, the consent is provided by the patient for direct care. Any other use of the data for such as research or for such as analysis or for such as any other reasons, we need to get consent from the patients to use the data for those purposes. So that level of governance allows the patients to have full understanding and assurance that the data they provide or exchange with the clinical professions is well looked after and used for the right reasons. That governance has to be put in place, and that governance needs to be communicated and has to be adhered across all the systems, So to ensure that all staff who work in the healthcare field, in the healthcare sector, have a yearly mandatory training of information governance. So they, although they know what they're doing, there is yearly assessment that they have to take on a regular basis, like health and safety training on the information governance of how to handle data, how to look after data, or how to use data. Does that answer your question? Or
Sí.
If I can just add to that.
Yes.
Thank you. Belly's response, I thought, was excellent. Yes. A microphone? Okay. Thank you.
Gracias.
Okay. I thought that Belly's response was
Pienso que
excellent.
la respuesta de Bala es
And
excelente.
what I wanted to do is to just
Lo que quiero
add further
hacer
context to that as
darle contexto
somebody who's worked in government, but
alguien que ha
also at
trabajado en el gobierno,
university
pero también en
in the health service.
el sistema de salud.
There's nothing more important
No
than
hay nada más
trust,
importante
and
que la
that this
confianza.
relationship that a
Y
doctor
esta
has with the
relación que el
patient is
médico tiene
built
con
on
el
trust.
paciente está
I mean,
construida en la confianza.
many patients, they go into
Muchos
hospital
pacientes
and
van
they
al
have to
hospital
trust that doctor when they
y
do heart
confían
surgery.
al
They open
médico
up their
cuando le hacen
chest,
una
they're doing
cirugía
surgery.
cardíaca y le
And
abren
so
el
they
pecho
give
para
their
operarlo,
trust to the
porque le
doctor.
dan su confianza al médico.
And this is a guiding
Y
principle in
este
our
es un
work
principio
as
guía
a
en nuestro
company
trabajo
ourselves, is that
como
we
empresa, que
treat the
nosotros
issue of trust
damos
really,
el
really
tema de
importantly, and that
confianza de
starts with
manera
the
muy importante.
development of the innovation
Comienza con el
itself.
desarrollo de la
We
innovación misma.
co-develop our technology
Hemos desarrollado
with and
conjuntamente la
for the
tecnología
clinicians
con
and the
y para los
patients.
médicos y los
And one of
pacientes.
the things that the
De
UK
las
has
cosas que el
a
Reino
particular
Unido
strength is in
tiene
public
una
and
fortaleza en
patient
particular,
engagement. You'll
que es en
notice
el
that almost all
compromiso del
R&D
paciente y
projects
del
and
médico. Todos los
in
proyectos
development, they
bajo
insist on public
desarrollo
and
se
patient
insiste
engagement along with the
en el compromiso
clinicians.
del público, del
And
paciente y de
all
los
the
médicos.
research projects
Y
that
todos los
we
proyectos
are
de
involved in,
investigación,
and I work for the
y yo he
from a
trabajado
research perspective,
como perspectiva
they
de
have to go
investigación,
through ethics
tienen
approval
que pasar a través
and
de
information
aprobaciones éticas
governance.
y gobernanza
And
de la información.
as Bali said, is that
Como dijo Bali,
the UK government takes
el gobierno del Reino Unido
this whole issue of data
considera todo este
governance very
tema de
seriously
gobernanza de
because
los
of the
datos muy
risk of
seriamente por
trust.
el riesgo de la confianza.
And I find that when I go to other
Encuentro
countries
cuando
around the
voy a
world,
otros
it's the same.
países
When I
alrededor del
work in
mundo es lo
Brazil,
mismo.
when I work
Cuando
here
he
in
trabajado en
Peru, when I
Brasil,
work
cuando he
in
trabajado en
Germany,
Perú,
they
trabajado en
all
Alemania,
treat data
todos tratan
privacy,
los datos, la
security
privacidad de
very,
los
very,
datos y
very
su seguridad
seriously, and it should be.
muy seriamente como
I
debería
just
ser.
wanted to share that.
Solo quería compartir eso. Muchas gracias.
Doctor Boya, adelante, por favor.
Sí, muchas gracias.
Ya para ir
Quizás
cerrando.
para,
Thank you very much.
quizás para los que están
Perhaps
ahí en Perú lo hago en español.
those who are in Peru will speak in Spanish
Sí, como mi acento un poco de
because
portugués, así que mis
my
colegas
accent
pueden
has
interpretar.
somewhat Portuguese accent.
Bueno,
Well,
a mí me parece para ayudar un poco eso, para
to help
hacer el
in
contexto más
put it
latino,
in
porque
more
sabemos
Latin
que la
context,
confianza
because we know that trust
no está o es un reto que
is
hay.
a challenge,
Tenemos
but we also have
digamos, una vista de salud que se va a
a health view that's going to change dramatically. So to think
los servicios
in
hospitalarios
the hospital services is extremely important, but sustainability is not going to come from this part alone. So to think in the data as preventive, we're also going to need to connect with the person. And our experience working in the Nordic countries is not enough that data belongs to you, because we need to move the concept of being yours, also have the concept of solidarity. How can you put value for the society? Because if you protect everything for you, there's no knowledge for others. Only works you as a country and develop the field that we can accept. And trust is there extremely important. The only form that I can see that we can do this is to be very strict governance or traceability of the data. So you as a person, regardless if it's a public or private sector, you see that you use your data, and we're going to need to use the data for primary causes, but also secondary. But anonymity is no longer exists. That model doesn't work. So that needs a development that perhaps can be done in the Andean countries, because there's a need to start from scratch with those thoughts. Thank you.
Muchas gracias, doctor Boya. Ya última intervención. Doctor Bala, por favor, adelante.
Dr. Bala, your final intervention, please. Your mic is off. You need to unmute.
Sorry. I said that was a very point to say about the efficacy of data. I was just going to add, I mean, within the constraints of what the UK government has approved and how that system works within our nation, is as you know, we have a very clear understanding of GDPR, and also we have every citizen has got access to freedom of information. So they have the rights to go in and challenge how their data has been utilized. Privacy is heart of that trust that we talked about. And so people need to understand, I mean, they will consent to data being used for secondary use, provided they are given the assurance that the data is used for the greater good. And so, we don't have any issues of accessing data for secondary use, be it research, be it population health, be it data-driven, understanding of the lay of the land. But at the kernel of that is people need to be assured that individuals need to be assured that the data is used in the right sense and for the right reasons. And that is the kernel. I mean, the huge issue with access to data for AI companies is that the data set that needs to be provided can be anonymized. Organizations can de-anonymize the data if needed, but that gives them the assurance that the system that is going to be learning and involved in clinical decision at a later date is robust and has the ability to use the data for the greater good. but that we have a duty of responsibility for the pay for, as I said, custodians of the data for the individual citizens. I think, but I fully appreciate the approach that other systems may have. Thank you.
Muchas gracias, doctor Bala. Bueno,
Thank you,
agradecemos
Dr. Bala. We thank
las preguntas
all
realizadas.
the
El
questions.
tiempo nos apremia
We run out of time,
y seguramente más adelante
and I'm sure that later
tendremos
on
en cuenta para
we will
definir los
consider them to
próximos
define
webinars
the
y
next
valoramos su
webinars, and
participación
we
en
value your
ellos. Ya
participation
para
and your
ir
interest.
cerrando,
To close,
le doy la palabra al
I give
doctor
the floor
Mestas,
Dr. Ciro
viceministro de
Mestas,
Prestaciones, Seguros
Vice
Médicos.
Minister
Adelante, doctor, por favor.
of Health. I'll speak strong, louder. Thank you to the Dr. Wilkins, Dr. Bala. We're becoming friends through Zoom meetings. Dr. Bogi, thank you very much for everything. With Horas Conu in the Andean countries, we coincide in something very important, that we want that clinical records of the future will be digital, because we can work, we can analyze, and we can be useful for decision making. So our goal is to have digital data at the point of care. About the standard, think that the standards, we are working with Horas Conu, so we can have first semantic standards of interoperability before standards for data transmission. As the speakers has already mentioned, the engineering work has been solved by them. The phone companies work rather quickly with interoperability. So our task with Horas Conu and the Andean countries is to define and adopt the interoperability semantic standards. Something very interesting that I wasn't aware of, that the UK is in a transition to a structured database. I think that in this regard, we have an advantage of having our information system being born with structured language database. So we're no longer going to go through this task of going from free text database or a different type to structured database. It's an engineering issue, but we do it with a principle of creating local capacities, local capacity building, so the local health systems in an area, the Andes, so diverse, would not depend on the capital cities or the region or the department or the country, but there is a local capacity building, and they can manage the data locally for decision making and for caring for people. More than curing people, take care of them, look after for them. And this is the vision of the future, the way we see it. With this vision of the future, the data of children who are born from now on are digital, are born digital, because perhaps there won't be the records of all of us sitting this today. What was our birth weight or height or our APGAR at birth? But the children who are being born now, we need to have digital records, the structure based on the international interoperability standard for example, the APGAR score. So these children that are going to govern the world, we don't know how this world is going to be the next century. They have health data that were digitally born. Otherwise, we're going to have what we have now, data cemetery in paper, a graveyard of digital data that we cannot use. So our data, with a responsibility with the future for the Andean countries, have to be born digitally with international standards and can be used for the benefit of patient care and with all the safety standards for the benefit of the population of the countries and finally the planet. Thank you very much, everyone. Now, Dr. Calle, for the closing words, our Executive Secretary, and to thank on behalf of the Indian Health Organization, Hipólito Unanue Grameen. Go ahead, Dr. Calle. I think it's been an excellent webinar. We've been very lucky with the presentations. When we talk about digital health, we're talking about applying technology to healthcare. That's the topic. And with the presentations that have been presented by different angles, and we can use mobile health applications, that we can have electronic medical records, that we have telehealth, telemedicine. In other words, we talk about everything a little bit. And we also mentioned large, significant truths. We are countries with different degree of development, but the most important, I believe, is when one shares knowledge to learn from the other one, so we don't walk the path that has already been walked. So what the Vice Minister just mentioned is very clear. I don't have to repeat it. But my point is that it's very important. This is technology, right? These are tools. This doesn't replace human beings. And there's something that we always say, with the medicine is art, science, technology, and humanism. Oya clearly said when he talked about dignity and solidarity. It was mentioned by our colleagues from the UK when they spoke trust and respect to data. But we all coincide that we want the common good. Because I think that that is the most important reason and the goal of the Hipólito Agreement, contributing to improve the health and well-being without differences, because we all have the right to everything, and at a higher level of system health level. And finally, let's not forget the approaches. When we talk about life course approach, we're talking about that, of being digitally born to be follow-up. But let's not forget of an approach that I'm very strong, because I'm convinced that which is the intergenerational approach. For me, that I'm in the 7th decade, I don't have 70, but very close to the 70s. Understand artificial intelligence is different for a medical student who's completing their studies. So we also need to take that into consideration. It's not that I replace one. I love when they say that. So we have people, they be treated igual, and we cannot treat them the same. We need to be conscious about that, but it doesn't mean that we should not do an ecological approach. What do I mean by this? Lines, laws, standards that are key. Also, it means that from the individual person that becomes updated and becomes aware. And I love what Singapore is being done. The Singapore story, that they are going to train all the people over the age of 40 throughout the country, so they are in tune with this topic. So we need that. Remember, this is a tool that's going to allow us to improve health, but we also to make this tool in a friendly tool that you can adapt and put in your routine. Thank you very much. for being here, Professor Wood, all the speakers who all have participated, Dr. Perez Blue, Dr. Curioso, thank you for being with us. Due to time, we're going to stay here to continue discussing. But thank you very much. Our next webinar is with the British Embassy is going to be mental health. We say at this moment it is a world emergency. Thank you very much. See you. Bye, Dr. Bala.
Thank you. Thank you for having me.